Good afternoon, everyone. Director General Dr. Nageshwar Rao sir, Academic Convener Dr. Ishwar sir, all the faculty and senior and junior residents to today's afternoon program of clinical case discussion of interesting cases. So today we have 4 cases for discussion. The first case, xylophone lesion from Department of Gastroenterology, ankylosing spondylosis from Department of Neurology, advanced laparoscopic solutions for complex conditions from Department of General Surgery, multiple myeloma from Department of General Medicine. So we'll start with first case, xylophone lesion from Department of Gastroenterology, presented by Dr. Harikrishnam Raju, Junior Resident General Medicine, moderator Dr. Bhaskar Rao sir, Gastroenterologist.
Myself, Dr. Harikrishnam Raju, General Medicine Resident, and today I am presenting an interesting case of xylophone lesion, and my moderator is Dr. Bhaskar Rao sir, General Gastroenterologist. A chief complaint: a 69-year-old male patient came to OPD with chief complaint of black color stools in standards, general weakness in standards, fever for 4 days, 50 days back. History of pathogenesis: patient was in usual state after 15 days ago. Since then started complaints of high grade fever, intermittent type for 4 days, not as with chills or rigors, associated with body aches, due with medication. Complaining of black tarry stools in standards, insidious onset, progressively persistent, foul smelling, sticky, and not associated with hematochezia. No complaints of hematosis, no complaints of abdominal pain, gastric burning or dyspeptic symptoms, no complaints of jaundice or abdominal distension. Past history: known case of hypertension since 10 years. Personal history: mixed diet, appetite decreased, normal bowel and bladder habits, sleep normal, no predictions. Family history: no history of similar complaints in the family. Hospitalized history: patient visited a private hospital at Gunda for evaluation of melanoma, for which upper GI endoscopy was done and diagnosed as delphi lesion, and hemoglobin was done 7 days ago. Drug history: tablet esmoprazole 40 mg, tablet domperidone 10 mg, syrup sucralfate 10 ml 8 hourly, and tablet metoprolol 50 mg. General examination: patient is conscious, coherent, oriented, moderate lipid and well nourished. Vitals: PP 170, SpO2 99% with room air, respiratory 16 per minute, temperature equilibrium, and pulse rate of 95 per minute. Pallor present, no icterus, no cyanosis, no clumping, no lymphadenopathy, no pedal edema. Vitals at the time of presentation: 100 pp, 100 by 8 mmHg, pulse rate 95 beats per minute, respiratory 22 cycles per minute, temperature equilibrium, chance 99% with room air, and GRPS of 118 mg per deciliter. Serious examination: pulse regular, normal rate, JVP not elevated, apex speed left partial space, mid clavicular line, response to heart, no murmurs. Respiratory system: brachia was central, bilateral chest expansion was equal, bilateral normal vesical birth sounds, no added sounds. CNS: patient was conscious, coherent, oriented, higher mental functions were normal, brain nerves was intact and normal, motor system was normal, sensory system was normal, and no focal neurological episodes were noted. For abdominal examination: inspection, abdomen is scaphoid, no dilate veins are striated, no visible peristalsis, no tenderness, no carding, no rigidity, no pool mass, no organomegaly. Percussion: tympanic node was present throughout the abdomen. Auscultation: vowel sounds were present. Provisional diagnosis: recurrent upper GI bleed, secondary to delphi lesion. Investigations: USG abdomen pelvic grade 1 fatty liver. This was the hemogram at the time of discharge from the outside hospital after hemoclipping, where hemoglobin was 10.2 grams and WBC count of 11,400, platelet count of 288,000 and RBC of 3.33. CBP at the time of our hospital admission, with hemoglobin of 7 grams, total WBC 6,200 and ESR of 45, MCV 81.7, peripheral smear showing microcytic hypochromic type of anemia with adequate platelet count. And for 3 days. And yes, sir. No, sir. Only CBP was available with him, sir. What? CBP discharge summary was available, sir, and the CBP at the time of discharge were available with him, sir.
No stool exam, nothing.
No, sir. No. And the serum electrolytes on the day of admission was sodium of 142, potassium 3.6, chloride 106. And virus negative, RFP showing urea of 70 mg per deciliter, create of 0.7, coagulation profile, prothrombin at 12.8, INR 1.1, and APTT of 25.9. Treatment on day 1, 1 unit package cell transfusion was done, and injection pant of infusion of 8 mg per hour, and injection tranexamic acid 500 mg 8th hourly, injection ondansetron 4 mg AV 8th hourly, syrup sucralfate 50 ml per hour 8th hourly. treatment on day 2, one more unit of blood transfusion was done, and remaining treatment continued. And an upper GI endoscopy was done on after stabilizing and optimizing the hemoglobin, and which showed oozing of blood addition to the clip, which was managed with organ plasma coagulation. These were the upper GI endoscopy images. Outside hemoglobin. Yes. So these were the gradual increase in the hemoglobin. Yes. So final diagnosis alcoholism presenting with recurrent upper GI bleed managed with organ plasma coagulation.
GI is a rare condition. Sometimes these lesions needs a combination therapy, and also they are better for presenting with recurrent GI bleeds. Combination therapies, injection therapy, endoscopic tubing, and sometimes organ plasma coagulation. If the bleeds are recurrent and repeated, which are not responding to endoscopic therapy, then we may need surgical or angiographic embolization.
What is the failure rate of hemoclipping?
Almost
how much time?
3 days back, sir. 3 days back, sir.
After clipping 3 days?
Yes. Here we again done other endoscopic procedures for coagulate the plasma and stop the bleed, sir.
Any comments from the surgical faculty who have seen this case and operated in the past? When the era of non-availability of organ plasma coagulation.
Endoscopy is available. Since we are doing my postgraduates, endoscopy was available. They were actually injecting sodium tetranickel sulfate or injection antibiotic around the lesions and all. Clipping came later on, and APC, organ plasma coagulation, recently they have been doing. Actually, APC is the treatment of choice for such lesions. As of clipping and all those things, we are avoiding.
Therefore, they would have done clipping and simultaneously that point. Not for want of recurrence. Otherwise, the recurrence rate is good.
Endoscopic process also, so almost 10 to 20% cases they may not respond to endoscopic treatment. Sir, at those places we have to go for angiographic embolization.
What is anatomical lesion? Why it is resistant to the therapies?
So the basic anatomical lesion is usually it is along the lesser curvature of the stomach, sir, most common.
Not interested. I asked
Arteries.
specific
Large arteries.
Not arterial.
Borrowing another glucosa, then it's coming out. That's how it will be. But who is he? What is the name of the person who diagnosed? What is his name? How do you say it? What is the name of the heading of the surgeon? Is a surgeon and physician. Okay, then what? He has 3 diseases in his pocket. And how many of you have gone and seen who is this fellow? You never heard. I have heard but I forgot. So I referred. Who is he? He is a French physician. And he has 3 names, 3 diseases, one name. Another thing which today when I read, it was amazing for me, I never heard of that when I was a student. He said components of Dulefy triad. Curiosity to make all the residents to go and see this. Now we have a cell phone, just go, you will have just got his name, everything will come in 2 minutes. You know, cutaneous hyperesthesia. Triad. The diagnosis for appendicitis. See, cutaneous hyperesthesia, what he has, their involuntary muscle guarding, wherever the appendix is there, and tenderness of my body is point. So, another thing is I found some apparatus, which I don't know about it, thoracensis. For thoracensis, there is a pump-like device used is known for these 3 innovations. So we don't know about these things, but this is not the way that I know. This is always artery. That's why these people are average 7 grams. It was so Not about 3 days he lost, or before that also. How many cases have you seen? Jagan has seen, so you saw him.
It is not that uncommon enough.
Thank you. All of you should go and once this was said, just see who is this fellow. Let us know about him. And his name there is a reason. Okay? That curiosity, unless you have that, you will not learn by your own. On your own, you will not learn. That's not going to help you to become wiser. Or by yourself to know and tell. That should be the attitude you should develop. Thank you. Keep on telling. Terminate.
Patient has and melena subset after 3 days, and patient was on follow-up and no episodes of melena were recorded and no hemoglobin drop was documented. So 1 year. 1 year has been 1 year.
What is organ plasma coagulation? They are gone, not organ. The presenting the case is tell me something about this.
Stabilizing the bleed.
Country ATC. ATC tablets and your acetaminophen and caffeine. But this is different. And I am not asking the question, what is the relation of organ gas difference to coagulation activation? That you should also study and come back. Not simply presenting the slides to the audience. Alright, sir? As a resident, you have to do that much more.
Next case, ankylosing spondylosis from Department of Neurology, presented by Dr. Raju, Junior Resident, General Medicine. Session will be moderated by Dr. Sujana.
Raju from the Department of General Medicine, presenting an interesting case of ankylosing spondylitis, the Department of Neurology. A 24-year-old man brought to hospital with complaints of low back ache since 3 months, aggravated since 1 week. Patient was suffering normal 3 months back, and the presenting complaint started as low back ache since 3 months, aggravated since 1 week, which is gradual in onset and progressive, was at night and early in the morning, delayed on movement and eating painkillers, associated with bilateral buttock pain, no issue of trauma, fever, weight loss, and neurological abscess present, no complaint of headache, nausea, vomiting, no complaint of muscle blindness, causing from uploading of eyes and involuntary movements and involuntary depression and meditation, no complaint of shortness of breath, cough, freeze, chest pain, palpitations, no complaint of abdominal pain, loose stools, and decrease of pain output. Past history, not a known case of diabetic, hypertension, and hypothyroid. Personal history, patient is a non-smoker, non-alcoholic. Patient has normal sleep and appetite. Patient takes mixed diet, normal bowel and bladder movement. No known food, drug, and environmental allergies. Family history, patient father has similar history of back pain at the age of 28 years and got treated with NSAIDs. Patient is general examination. Patient is conscious, current, well-oriented to 10 years person. Moderate libido and BMI is 33 kg. No pallor, no ictus, no signs, no clubbing, no infection, no edema. Vital set presentation normal. Systemic examination, serious SPNS2 present, no mammals heard. Respiratory bilateral non-muscular breast was present. GIT, soft and bowels are present. CNS examination, patient is conscious, coherent, oriented to 10 years person, and it's a right-handed person with a irrigation degree. Cranial examination is normal. Moderate vertical examination. Attitude of the limbs are normal. Bulk and tone are bilaterally symmetrical. Power of both upper and lower limb are normal. Reflexes, both superficial and deep reflex is normal, and sensory examination is normal. Coming to musculoskeletal examination, this is a modified Schwaber test performed. It is performed by taking the midpoint between the posterior relaxed spine, 10 cm above and 5 cm below. On bending down, it should increase greater than 5 cm, but in this patient it was only 3 cm. Cerebral examination is normal, no meningeal or sides present, no spinal cranial defects present. The differential diagnosis include mechanical low back pain or inflammatory spondyloarthritis. Chest X-ray.
This is a frontal chest radiograph, PA view. Trachea is in midline. Cardiac shadow appears to be within normal limits. Bilateral lung fields are clear. Bilateral costophrenic angles are free and both domes of diaphragm are well outlined.
ECG is a toilet strategy ECG showing normal sinus rhythm. TDF shows now normal mortality with EF 60%, RF 20 No pericardial effusion, blood vegetation, eyes normal collapsing, MRI is
I have done echocardiography when he is a backache
suspicion of angioplasty.
Gettiga.
In suspicion of angioplasty spondylitis, any aortic regurgitation.
I had to all and I had to visit at times.
The sagittal T2 and stir sequences of MRI lumbar spine, where we are able to see subtle T2 and stir hyperintensities involved in vertebral end planes with vertebral body heights norm. These are curved stir images bilateral sacroiliac joints, where we are able to see bilaterally symmetrical stir hyperintensities involving bilateral SI joint, predominantly involving iliac aspect more than sacral aspect, while sacroiliac joint space is maintained.
If the joint space is compromised or the adjacent bone is abnormal.
Bones.
That is it. The stasis that part, what is the grade you like to make it by MRI? Calculate for it. Ready? No grading. Qualitative is not because quantitative. Why? When you treat it, is it worsening or normal? Survey are they jumping?
Both sacral joints, subarticular marrow, still hyperintensity noted involving bilateral sacral joints, symmetrical bilateral sacroiliitis, bile joint effusion noted on right hip synovium, cyst of synovitis. Complete blood picture shows non-cystic anemia with notified leukocytosis. This is the day 3 of CBC showing decreased WBC counts. We sent HLA B27 outside and suspicion of manganese chloride turned out to be positive and CRP was elevated. RF factor and anti-CCP both were negative. Our liver function is normal, virus negative, and Brucella was also negative. Lipid profile and serum lipids were within normal limits. Liver function test and complete urine exams normal negative. Treatment given was IV fluids and IV antibiotics. Injections given on IV 12th hourly for 5 days and levofloxacin 700 on 4th hourly for 5 days and LSX were given PD and continued for 3 weeks. This is the criteria to diagnose the angular spondylitis. Patient has back pain of greater than 3 months and the patient age is greater than 45 years and patient is a male person. It's a HLA B27 positive and other features like NSAID response, family history and HLA B27 was positive and elevated CRP was present and MRI showing the changes of angular spondylitis. Final diagnosis angular spondylitis HLA B27 positive. In this case, X-ray.
Doctor, angular spondylitis so much, then you should grade it. You must type it, you must scale it. Once upon a time it was not staging because blood surgery. There is no treatment except results. And they usually to give radiation with the complications of retroperitoneal sarcomas and all. Now you have got a very good treatment for angular spondylitis, depending upon the stage, depending upon the government and all this. And I do not know what neurological complications that to be associated with the neurology department. Comments? And if you like to make some comments, neurology classical presentation that we will hear.
So he came with a complaint of back pain, sir. Back pain. So
therefore, that goes to the department of orthopedics or general medicine.
but to evaluate because of his
Evaluated, you have taken the onerous responsibility of someone, sir. For which they should thank you and you should thank you. And you are presenting the case. Otherwise, it would have been presented to the department of orthopedics. But any neurological presentations are actually already because it has come from neurology. Arachnoiditis leading to commerce medullaris. Severe arachnoid is compromising the space of thermocentric. These are all ఈ గ్రేడ్ మీకు క్లినికల్ గా రేడియోలాజికల్ గా చేయాలమ్మా. ఈ ప్లేన్ ఎక్స్రే MRI లో గ్రేడింగ్ అది చెప్పుండాలి. దట్ ఈస్ యువర్ నాట్ డన్ యువర్ హోంవర్క్ ఫుల్లీ.
These are the gradings in the X-ray. Grade 0 is normal. Grade 1 shows blurring of particle movements. Grade 2 shows erosions and sclerosis of the joint. Grade 3 shows extensive erosion and widening of the joint. Grade 4 shows joint angle. The management makes sure of management in the ambulance policy, NSAIDs, nebulizer and ambulance, physiotherapy, and biological agents like anti-TNF alpha inhibitors and interleukin-17 inhibitors. Patient.
Any comments for the therapy with reference to the ankylosing spondylitis current by faculty of medicine? Any number? Because you need not go for parental component, you can give oral drugs. Biologicals are very costly and parental, but there is one biological equivalent which can be which is available as tablets of 11 milligrams. 11. That is the only thing which is abnormal. 11 milligrams in the entire market. Whereas others are 5, 10, 20 like that. This is available everywhere. If you give it in the stage 1 for incapacitating type of.
Patient was then referred to rheumatologist. They gave a professor.
Physiotherapy, wonderful. What is the best physiotherapy for ankylosing spondylitis? Because tomorrow case comes to you at the stage 1 as a resident of medicine. What is the best physiotherapy for ankylosing spondylitis? Because if you don't give physiotherapy or biological, you may go into a pulmonology component of restrictive lung disease. All 4 vertebrate animals have inherently known the torque, whereas human being has to learn it. So wonderful, swimming. Therefore, swimming is the best exercise, particularly backstroke swimming for ankylosing spondylitis. If there are no questions, we will go to the next. Swimming pool అక్కర్లేదు, విలేజ్లో అయినా తలలో స్విమ్ చేయొచ్చు వస్తే.
Condition that is the laparoscopic fundoplication for type 4 hiatus hernia with refractory GER. The patient profile: patient is a 56-year-old female, housewife by occupation, resident of Gannavaram, with the chief complaint of severe belching since 3 months, bloating postprandially, associated with heartburn, that is testosterone burning. Onset and course: it is insidious in onset and gradually progressive with no history of vomiting, dysphagia and weight loss. Past medical history: patient is a known case of hypertensive since 3 years and known case of hypothyroidism since 1 year and on regular medication, not a known case of diabetic, epileptic, asthmatic, CAD or CVA. Surgical history: patient underwent hysterectomy 15 years ago. Personal history: mixed diet, regular bowel and bladder habits with adequate sleep and appetite and no addiction with no significant family history. On examination, patient is well built and nourished. She is conscious, coherent, cooperative, with no signs of pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema, with stable vitals of temperature 100, pulse rate 76 beats per minute, respiratory 80 cycles per minute, BP of 130/80, SpO2 100. Parabdomen findings on inspection: parabdomen is obese, umbilicus midline inverted, suprapubic scar present, which is a hysterectomy scar, all quadrant move equally with respiration with no visible swelling, peristalsis or palpation. And palpation: there is no local rise of temperature or tenderness, no guarding, rigidity or organomegaly, and no palpable cough. On percussion, tympanic note is heard in all quadrants. On auscultation, vowel sounds are present. On correctal examination, normal finger tone and no abnormal finding. Laboratory parameters are normal. This is the 2D echo with mild concentric LVH. Patient is fit for the surgery with normal IVC and collapse. Normal IVC. This is the chest X-ray.
This is a frontal chest radiograph, TA view. Trachea is in midline. Cardiac shadow appears to be within normal limits. There is a soft tissue density lesion noted on the left side in the lateral aspect. This could be artifactual or any loculated pleural effusion. Bilateral costophrenic angles appear free and both domes of diaphragm are well out.
Ultrasound abdomen and pelvis with anosomological abnormalities are detected. Patient underwent upper GI endoscopy and the findings are prolapsing gastropathy and with associated type 4 hiatus hernia with antral gastritis. Patient also underwent high resolution esophageal manometry. Here the the blue indicates which is the low resting pressure and the green indicates the moderate resting pressure of the lower esophageal sphincter. The findings are normal manometric study with no evidence of aphasia or motility disorders and lower esophageal sphincter pressure within normal range and normal esophageal peristalsis. Here, the normal motility confirms suitability for fundoplication. Abnormal motility would mandate a partial graft, that is Toupet or TOR. Final diagnosis, type 4 hiatus hernia with refractory GERT with hypertension and hypothyroidism. Now, as the patient is on prolonged proton pump inhibitor therapy, now we have went for surgical intervention. GERT epidemiology and impact. 20 to 28% prevalence is present with 10 to 40% refractory rate with more than 8 weeks of threshold. The surgical indication for anti-reflex surgery are refractory symptom, large hiatal hernia that is type 3 or type 4 paraesophageal hernia, volume regurgitation or aspiration, patient reference to discontinue lifelong proton pump inhibitor therapy. This is the Hill's endoscopy grading. The patient has a grade 4, that is the lumen of the esophagus is open and allowing the epithelium to be viewed from the below. This is the anatomical classification of hiatus hernia. Type 1 is sliding, type 2 is rolling, type 3 is mixed, whereas type 4 is complex. The type 4 hernia carries a higher risk of valgus, obstruction and strangulation, mandating surgical repair. According to us, the patient has type 3, that is mixed both gastroesophageal junction and fundus herniation. Why to operate? Risk of non-operative management or obstruction, valgus, strangulation and emergency presentation. The golden standard, the laparoscopic Nissen fundoplication is the golden standard for definitive GERD and hiatal hernia through minimal access that is laparoscopic. Patient position and placement. Patient is patient supine or split leg or reverse Trendelenburg. The ports are placed at 10 mm, 5 mm in the epigastric, 5 mm in the right subcostal and 5 mm in the left hypochondry. Here the retraction of the liver is done. And the pars sets of the gastrohepatic ligament is ligated to mobilize the intra-abdominal esophagus. Here the right crura is dissected and the left crura is dissected. Here the right crura is dissected from the esophagus in the avascular plane, and the right crura is dissected. Here we are able to see the posterior vagus. The adhesions surrounding the esophagus is released. And the short gastric vessels are ligated from the stomach. Intra-abdominal esophagus is retracted down and shoeshine maneuver is done here. Here the fundus is mobilized below the esophagus and check for the fundoplication, that is wrapping. Crural repair is done here. We are taking the fundus of the stomach and then muscular part of the esophagus and the other part of the stomach and doing the fundoplication with 20 echelon. First step is to summarize the surgery. First step is the hydral exposure to retract the liver and then divide the gastrohepatic ligament and to expose the intra-abdominal esophagus. Second step is the crural dissection and repair. Here, the esophagus is mobilized by dissecting the right and then left breast in a avascular peri-esophageal plane. Then to preserve the posterior and anterior vagus, complete posterior esophagus window via blunt dissection for fundal path. Then the crural closure with 2 to 3 interrupted 10 echelon is done. Why vagal injury matters? Here, anterior vagus lies on the anterior surface of the esophagus and controls the gastric secretion and pyloric function. Posterior vagus lies in the peri-esophageal part posteriorly and controls hepatic, pancreatic and intestinal branches. Injury consequences which will lead to gastroparesis, bloating diarrhea or post-vagotomy syndrome. The third step is the fundus mobilization. Divide the short gastric artery and then mobilize the posterior fundus and create the posterior window. The fourth is the main step, that is 360 degrees Nissen fundoplication. The esophagus pass posteriorly fundus behind to meet the anterior fundus, creating a 360 graft and confirm flat untwisted graft, that is Shushan twist. The sutures are placed to a loose graft avoid the dysphagia, a short graft avoid gas duct. Graft calibration, the length should be adequate, that is 2 to 3 cm graft should be maintained. Looseness, the looseness should be maintained. A graft should admit 56 to 60 French bowl and then fixation and then orientation. Advantage of laparoscopic Nissen fundoplication for definitive reflex control, hernia correction, proton pump inhibitor independence and improved quality of life. Potential pitfalls and complications. Patient may lead to post-op dysphagia, gas blood syndrome, graft migration or failure and vagal nerve injury, which will lead to gastroparesis, diarrhea. Here the Nissen versus the partial graft, when to choose. The Nissen is the 360 degrees, which is a gold standard for best reflex control and for normal motility. Taupet is 270 degrees, posterior graft. Lower dysphagia risk may be present and good reflex control for impaired motility. DOR is 180 degrees anterior. Lowest dysphagia risk, least reflex control and post-myotomy. The patient has normal manometry, confining Nissen 360 degrees is the appropriate choice. Dietary guidance, post-fundoplication. Week 1, liquid diet is allowed, she tolerated and she is fine. Week 3 to 4, soft diet is tolerated, which includes soft cooked vegetables to avoid hard and fibrous food. Week 5 to 6, normal diet is allowed and the patient tolerated, avoiding carbonated drinks and large meals long term. Post-operative monitoring. 2 weeks there is assessment of dysphagia and early dietary review. 6 weeks patient came for follow-up and with no clinical symptoms. Follow-up is after 3 to 6 weeks. Evidence-based long-term outcome, 93% symptomatic relief, that is patient satisfaction at 5-year follow-up, 85% PPI free and 2 to 5% reoperative free. Patient selection, the key to success, this patient is ideal candidate with objective evidence of GERD, symptomatic refractory to optimal PPI of 8 weeks, normal or near esophageal motility with good surgical fitness. Related contraindications, severe esophageal motility, that is partial BRAF preferred, short esophagus, Foley's gastroplasty required, morbid obesity, bariatric procedure. This is the operative summary. Preoperative decision, type 4 hiatus hernia with refractory GERD with failed proton pump in conservative management and medical management with normal manometry and cardiac fitness confirmed. The procedure performed is laparoscopic Nissen fundoplication. Thank you.
Case is open for commentary.
And all those things where we are likely to do rectal malignancies and all. For this case, laparoscopy is okay, sir. We don't need robotic surgeries for such conditions, actually. This was the first case what we have done actually. And normally what third advanced laparoscopy cases. Other 2 cases will be projecting in the few weeks time, sir. Over here, the normal problem what we are having is we are getting a lot of cases of GRD. But actually, to take a decision for surgery, we need to have the manometric studies. Manometric studies we are not having in the institute. So we send the patient outside for manometric studies, and when they are going out, actually those patients are not coming back. It is being held by the other hospitals and they are operating on. So this case actually they came back to us. So we took the decision to do the case.
What are your comments on manometric studies? Such a costly affair, or you need a Oscar? Because according administrators should provide a manometric facility which can be
It's a medical
attached to your gastroscope.
medical gastrologist, Bhaskar should be able to test.
That's why I put the question.
It's around 30 to 40 lakhs.
Along with the scope.
Yes, sir. Yes, sir.
It includes the pH monitor and all sorts of things.
Yes, sir.
30 lakhs. It is
Because this is becoming a common condition, actually, sir. GRD, reflux, and all that. So if you have these
part
studies,
of the metabolic syndrome.
yes, sir.
Is directly proportional to the quantum of wasting ratio. Therefore, it is requested to the authorities to
Last case for presentation today, multiple myeloma from Department of General Medicine, presented by Dr. Deepika, Junior Resident. The session will be moderated by Dr. Surya Tejas.
Good afternoon, everyone. I myself, Dr.PInnamaneni from Department of General Medicine. Today, interesting case is unmasking multiple myeloma, a case of bone pain and severe anemia. Moderator Dr. Surya Teja, Chief Complaints. A 65-year-old female presented with complaints of breathlessness since 2 months and bilateral lower limb swelling since 2 months, with pain at left groin radiating to medial side of left foot. History of presenting illness. Patient presented to general medicine OPD with complaints of breathlessness since 2 months, which is progressive in nature from grade 3 to grade 3, not associated with orthopnea and PND. Patient also noticed bilateral lower limb swelling for the past 2 months, which is insidious in onset till angle. Complaints of pain at left groin region for the past 3 weeks radiating to medial aspect of left ankle. The pain is dull aching in nature, which is persistent and aggravated with movement or on standing. There is no history of
little
trauma.
bend towards the mind. Audible.
There is no history of trauma or fall. The patient reports generalized fatigue over the past 3 weeks, significantly impacting daily activities. No history of weight loss, no history of bleeding manifestations such as epistaxis, melena, gum bleeding, and hemoptysis. No history of abdominal pain, fever, chest pain, mounting, loose stools, burning, agitation, or decreased urine output. No history of involuntary movements or altered sensorium and loss of consciousness. Past history. Patient present to outside hospital with complaints of back pain. Where symptomatic management has been provided and patient was discharged after collecting a HP with 4 pins PRBC 1 year back. Patient was admitted in outside hospital 5 days back for left groin pain, and in view of low HP, patient was transferred with 2 PRBC. The patient was referred to Dr. SIMS&RF for further management in view of back pain and low hemoglobin. She is not a known case of hypertension and type 2 DM, CVA, CAD, CLD, or CKD. Personal history. Patient is complained of decreased sleep since 3 weeks due to pain at left hip. Appetite is normal, she takes mixed diet, all and body movements are regular. Family history is insignificant. Menstrual history, cycles are regular. She attained menopause 25 years back. Obstetric history, P2 healthy with no history of abortions. Vitals at presentation. BP 130 or 80 mmHg, pulse rate 92 ppm, respiratory 18 counts per minute, saturation with 97% at home air. She is affected with GRPS 84 mg per deciliter. General examination, patient with his conscious, coherent and oriented to place. On examination, pallor is present with no icterus, sinuses, clubbing and lymphadenopathy. Edema is present which is grade 2 bilateral, pitting, slow feeling in nature. Nail beds are pale in color. Systemic examination. CBS S1 S2 heard with no murmur. JVP is elevated 5 cm above sternal angle. Venous sound is present. Respiratory bilateral normomuscular bell sounds and no added sounds are present. Parabdominal soft and non-tender bowel sounds are heard. CNS examination, non-focal neurological deficits with GCS-15 in people bilateral NSR, non-specific reacting unit. Left lower examination has been done in view of left lower hip pain. On inspectory findings, no sinus or scar engorged veins, deformity, no limb length disbalance and muscle wasting. On palpation, there is no local rise of temperature or tenderness. Movements, there is no restriction of movements. Provisional diagnosis, severe anemia under evaluation might be due to iron deficiency anemia, anemia of chronic disease or myelodysplastic syndrome based on patient history and age. ECG, this is a 12-lead sinus rhythm, 12-lead ECG with normal sinus rhythm. CBP on day 1, HP 7.1 gram, ESR 50 mm per hour with platelets 154,000. Peripheral smear is normostatic, normochromic. RFTs are normal, uric acid is 7.8 mg per deciliter, electrolytes are normal, magnesium 1.44 mg and calcium is 7.3. Corrected calcium is 8.1 mg per deciliter. LFT showing AG reversal with serum albumin 3.1 gram per deciliter and globulin 4.9 gram per deciliter. C is normal. Ultrasound abdominal pelvis impression, mild hepatomegaly with grade 1 fatty changes. Study echo, there is no LV-RWMA with good LV function of 60% and decreased diastolic compliance. No MR, TR or PH and RVSP 20 mmHg. IVC is normal and collapsing. X-ray chest.
This is a frontal chest radiograph PA view. Patient is in mild rotation. Cardiac shadow appears to be mildly enlarged. There is a non-homogeneous opacity noted involving left lower zone. This could be consolidation or any pleural effusion. Right costophrenic angle appears free and both lobes of diaphragm are well outlined. There are vague, ill-defined osteopenic areas noted involving both clavicules.
Would you like to comment further? Was clavicles? Because a good radiologist comes to see the clavicle should suspect the history of anemia. The first thing that is clavicle, much more so on the medial. That is in good olden days, British non-radiology series, not clear notes. Good.
X-ray spine.
These are X-ray spine, AP and lateral views. There is generalized decrease in bone density noted involving the visualized bones. And degenerative changes in the form of bridging osteophytes noted at few levels in the dorsal spine.
X-ray pelvis.
This is X-ray pelvis AP view. There is mild there is degenerative changes in the form of marginal osteophytes noted in the visualized bones. Phlegoliths noted in the pelvis. Osteopenic areas noted in the head of the femur, intratrochanteric region and ischium on both sides.
CD pelvis.
These are axial CT pelvis soft tissue window, where we are able to see undisplaced fracture in the left pubic bone in the parasymphysium region, and adjacent operator externus muscle is swollen and stiff. Could be due to old fracture with soft tissue formation. These are axial CT pelvis bone window images, where we are able to see multiple diffuse osteopenia with multiple ill-defined osteopenic areas involving bilateral pelvic bones. The same features, and in uterus we are able to see subserosal fibroids with evidence of acute calcific propate. We are able to see L5 vertebral body collapse. These imaging features are in history of infiltrative neoplastic diseases like multiple myeloma. Other differential would be lytic metastasis.
Total of left lower limb, which is done at outside hospital. There is fine hyperechoic area noted involving SFJ with non-compressibility and adjacent subcutaneous edema noted in anterior compartment of neck. Might be early DVT. Enlarged inguinal lymph nodes noted, the largest measuring 18 into 9 mm. Subcutaneous edema noted involving anterior and posterior compartments of left lower limb. Signs of cellulitis. Treatment on day 1. Pumping PRBC transfusion has been given and IV fluids with 1NS with optimal at 75 ml per hour. Tacferrisone 30 mg per oral OD and carfentanil 40 mg per oral once a day. With ultracide per oral SOS and febuxostat 40 mg per oral once a day. Gabapentin NT 75 by 10 per oral once a day. Workup of anemia. Peripheral smear is showing normocytic normochromic RBC and serum iron is in normal range. Ferritin is elevated, which is 1500 nanograms per ml. Serum erythrocyte count is 2.26% and corrected retic count is 1.23. TSH is normal, SOBT is negative. Vitamin B12 is excess, might be due to supplements. LDH is 173 units per liter. BTCT 2 and normal. Bone marrow aspiration analysis. Both erythroid and myeloid series are decreased in number. Megakaryocyte series decreased in number. Myeloid to erythroid ratio is 1:3. Myeloid series, promyelocytes are 2%, band forms are 4%, neutrophils are 1%. In erythroid series, plasma cells are showing 145%. Impression might be multiple myeloma.
These are the high power magnification image of the bone marrow aspirations media, showing hypercellular marrow with more than 40% of the marrow cells, showing plasmablast with the increased nuclear cytoplasmic ratio and eccentric nucleus with the prominent nucleoli and basophilic cytoplasm, and fewer binucleated forms are also seen. Next.
Bone marrow cell block.
These are the high power image of the bone marrow cell block showing hypercellular marrow particles, predominantly plasmoid cells, based on all morphological features, are given impression of multiple myeloma.
PPINR normal in range. Sportin analysis. Sportin microprotein is 211 mg per deciliter. Creatinine is 44 mg per deciliter. Sportin PYC ratio 4.8. 24 hours MBD is 2624 mg per day. Benzone's proteins are negative. Gastroenterology was taken in view of anemia to rule out any malignancies. I advised approach endoscopy and colonoscopy. Orthoreferral has been taken in view of left groin pain, advanced injection viral SOS, tab brainstorming, PG12 once a day, tab Gifina camera, oral BD, tab calcium citrate for oral 12 daily, tab Lloyd D3 60 km once a week. Immune fixation electrophores showing both quantitative and qualitative analysis, revealing IgG 64.44 and lambda free chain on 65.11 mg per liter. Immune fixation electrophores of quantitative of kappa free light chain and lambda free light chain analysis. Kappa over lambda ratio is 0.002. Quantitative analysis, IgG is positive. Graphical representation of IgG lambda. Serum protein electrophoresis, albumin is 2.4 gram per deciliter. Hemoglobin is 5 gram per deciliter with total protein is 9.31. AG ratio is 0.36, which is reversed. And band is present. Impression of monoclonal band of 1 gram per deciliter seen in gamma region. Beta 2 microglobin is 10 micrograms per ml. Serum protein electrophoresis representation. Impression with monoclonal band of 1 gram per deciliter seen in gamma region.
Can you go back to the electrophoresis? Let me show me where the beta 2 plant.
Defining features of multiple
is acronym, right? GRAB is an acronym.
Alright.
So what is C?
Defining criteria for multiple myeloma.
Huh?
Defining criteria for multiple myeloma.
No, louder.
Defining criteria for multiple myeloma.
So what is the C?
C for calcium levels here.
Why did they have 6 where I didn't know.
It was advised by ortho department. Ortho department.
What is B?
Bone lesions, sir, might be osteoporotic lesions or bone pains.
Sir, actually, that is for the defining myeloma events. Patient's calcium is on lower side. 7.3 is the calcium. Her actual calcium is calculated 7.3 milligrams. So, for that reason, we have given calcium. Hypercalcemia is one of the myeloma defining events, but patient doesn't have hypercalcemia.
Patient's calcium was 8.1. What are they doing? Now, do you want to do calcium or not? Do you want?
Symptomatic need not be infectious.
You have to look into the renal function before you give a calcium of the things. Because the hypercalcemic state is directly related to the quantum of function of kidney. And the turnover of bone is safe whether it determines the calcium is determined by the kidney physiology. Alright, sir? Along with fever, but uric acid is not determined by the kidney physiology. Before that, uric acid goes because the cell turnover of the quantum of grade 3, 1, 2, and stage 1, 2, 3, 9. 1, 1, that is the fourth big piece. What is beta 2? Which you should circulate out because that is the prognostic component of the treatment. And the moment it comes down, this comes down. The right peaks are above, left peaks are above. Can I take a separate comment?
60% or more chromosomes in bone marrow. It's not. Light chain ratio of serum involved to uninvolved greater than 100 is not done. MRI with greater than 1 population is not done. Calcium weight greater than 11. Patient calcium is 7.4. Creatinine is 0.7. Defining features are only bone lesions and anemia HP less than HP 7 gram per deciliter. Revised international staging system 3/4 present. Beta-2 microglobulin is 10 micrograms per ml, albumin is 2.4 gram per ml, and LDH is 173 units per liter. Cytogenetics are not done. Final diagnosis: multiple myeloma, IgG, lambda, shape. International staging system stage 3 with left organ deletion. Patient was referred to oncology center for further
Before
management.
that, I like to have the comments from the assistant who dealt with the space and some questions.
Sir, on the day of presentation, myeloma is not even there in the differentials where we have thought of. The only complaint what made it so suspicious is the patient has not having any good sleep for the past 3 to 4 months because of her bone pain, which has not been addressed in spite of 2 hospital admissions that she had in this time.
Therefore, what is the clinical criteria to suspect that lady has myeloma?
She has
Suspect.
atraumatic
Suspect in the case. I suspect my brother has
atraumatic fractures and bone pain in an elderly female recurrent anemia.
60 plus. Anemia 60 plus, rule of 60 clinically with nocturnal disturbed sleep with pain. Disturbed sleep with pain. Even neurology. Even a radicular pain will not disturb the night sleep. The only pain which disturbs the night sleep is metastasis and therefore disturbed sleep in female. And male, all the 60 rule of below 60 hemoglobin, age above 60, and ESR above 60. The tried name for that is called clinical diagnostic suspicion. On background of bone pains which disturb the sleep is extremely specific plus 90 And you have to do a peripheral smear and find out if the peripheral smear shows more than 2 plasma cells sufficient, not bother about with abnormal cells and normal plasma. It is abnormal. That is how it was made, I think so.
It was made by you, sir.
Now treatment. Once you confirm it, you can do. Now what do you do?
She underwent 5 cycles of chemotherapy with bortezomib and zoledronic acid and dexamethasone pentamidine has been given into injections of daratumab 400 mg.
What is the bath? What is the bath?
Protease inhibitors, sir.
Protease
inhibitors. Proteasome inhibitors. Proteasome inhibitors.
Question. Oncology.
Its right chain component is common. Which one did she have?
This is lambda.
Which is common.
What is asking the question?
What is the
Light chain amyloidosis.
Which component? Which light chain amyloid and which light chain?
This is the same reverse.
Lambda is amyloid.
That is actually with
there is one thing which is different in this case. Kappa and second, put the diagnostic criteria, right? Is it multiple myeloma?
Any one of the criteria is enough to diagnose multiple myeloma. Greater than 10% prevalence.
I am not interested in any of these international association criteria. They see the marrow. If the marrow contains atypical cells more than 5 to 10%, it is unequivocal evidence of myeloma. Irrespective of the immunofixation, irrespective of dying, irrespective of genetic markers, irrespective of other things. That's all.
It is a disorder of itself. Non-related antibody production.
No. It is a disorder of plasma cell. Plasma cell. There are the B cells which become plasma.
Non-related antibody production.
Any comments from the pathology? We have disorder of plasma cell. That's why it is called plasma cell displasia. But B cells become plasma cells, or they are different from them? That is the question.
Which antibody? Which antibody would be for this? The B cell disease, right? Which monoclonal antibody would be for this? Autoimmune disease would be monoclonal antibodies. Which monoclonal antibody would be? Lupus, B cell disease, and B cell disease.
They are not monoclonal. Adi chapagala.
Which antibody would be? Which monoclonal should be for this? Why got this due to this? It's not, it's a proteome inhibitor, right? Why are we not giving a monoclonal antibody? Autoimmune disease, we have to inhibit antibodies. For the autoimmune disease, antibody production, inhibiting antibody production, would you fix monoclonal antibody? Okay, sir. Anti-inhibiting. Would you fix that? So you also want to inhibit antibody production. Why not fix like what is it?
In other words, a non-specific immunoblastic suppression, whereas a specific immunoblastic suppression lead to
you know the difference between why rituximab is given not given and why bortezomib is given, then you understand why rituximab does not work in reverse. It is not a body treatment for autoimmune diseases. Rituximab acts only on the up to the ending of disease, not in the plasma cells. Your antibodies are produced by plasma cells. So they do not act on the plasma cell which are already formed. as well as the B cells which are in the deposits. Only the new forming B cells will be inhibited by this method. Despite how much of the rituximab you give, the antibody and the plasma will not respond. That is one case caused by rituximab placing. That is why you want to target the plasma cells. The actual antibody loss rather than target.
That is a B cell. This is transformed cell. Why I asking that question lambda is the last surgery when there is no treatment except for post radiation and some other all that comes. Ungulating agents and other things. The treatment will learn with the amyloidosis of the kidney. The two common causes of autopsy amyloidosis of the kidney is osteomyelitis bone, the other one is myeloma, and chronic tuberculous infection of joints untreated. Because come in.
Just have a why did they give lenalidomide or thalidomide disease? Can you? And there's a patient that developed
he has no neuropathic symptom.
He has neuropathic symptom before treatment, after treatment,
If the neuropathic symptoms occur in a myeloma, that is the question. You have to think beyond.
Patient has advanced myeloma, presents to the body symptoms or thalidomide. There is an enhancement of the respiratory. Versus all those therapy after treatment.
Third, in the plasma cell component of displacement, multiple myeloma stands as a unique component of very highly specialized, despite uncomplicated, pure plasma. The rest of the things towards the spectrum of left or to the right will have more amount of neurological problems with the abnormality of chain synthesis involving, that is, Castleman's, Boyens, and so on. And towards the left, you will have a small chain, that is, heart chain, maybe light chain diseases, and so on, and largely. Therefore, this patient doesn't require the question thalidomide. When he can require, we are going giving that biologicals forever and ever. Then we have a maintenance component when it comes to development. It can be given second generation of thalidomide.
Infections. We have high globulins. Immunoglobulins are high. Is it only infection?
Yes, sir. Autism causes simplex. Not on the fungal infections and
he had plenty of immunoglobulins, but he suffers with the infections. That's the question why.
Which type of infections you want to prevent? Your choice of antibodies depends on which type of infection you expect in this case.
You know what is the commonest cause of death in myeloma? All are differently produced and then united, like you are compact where the vessel is very cord. The cord outer ring is cord material and the engine comes from there, not inside. And they resemble it. The immunoglobulins are resembled like that. Heavy chains and light chains differentially manufactured. Each one is committed a plasma cell. After stimulation of beta cell by the memory of the B cell, induction, it converted into a plasma cell, that is immunoglobulin, immunoblast. That synthesizes differentially. Then they will evolve. In myeloma, it forgets to synthesize. It synthesizes one, other one synthesizes one. Both will not have assembly. A car is not produced. Engine is different, and body is different. Therefore, it doesn't travel. When the human and body are in the same, they become immunologically competent. When they are different, they become immunological assault to the entire system, and every system gets targeted. That is either by heavy chains or by light chains. But myeloma is both heavy chain disparted differential production of deviant light chains, not coming. That is the structure. They are more prone for capsulated infections, and that's why you should give a pneumococcal vaccination and so on. Abhishek? The load is reduced?
Yes.
At the done bone marrow, how you do bone marrow for follow? Or you go by your immunoglobulin or electrophoresis. Every time electrophoresis, pathology. How do you pronounce the remission of plasma multiple myeloma as a pathologist? No? No evidence, no criteria for remission. Do. And they become less than 2% narrow, and nothing is painful here. It is deemed to be a proven remission. Collaborated with the immunological estimations of the disease. Or best thing is we can do more questions? We must have a transplant.
Bone marrow transplantation can be done under no comorbidities.
No comorbidity. I say that myeloma is cured. Any more questions? Yeah? The quantity the sometimes is pain only. The last thing to come down. With the very bad pentagon and the alphabet, but there is no kidney involvement. There is a kidney involvement, but there is a tough thing to
Thank you.
question from this side? Wrong time?
2019 Corona stopped. Still inpatient. So I would like you, adore, be nice to the patients, see that there are more patients will be coming forward. This is where we want material for your heart. Be nice to the patient. Put all your efforts. Spend more time with them. Be passionate and see them